This is the webinar about fertility preservation in patients with endometriosis. And it's a real pleasure to be talking to you today. I want to thank the invitation by the EEL. And in these strange days that we're living, where everything is about the virus, I think we will discuss a little bit about our favorite disease, which is endometriosis. And very especially about the topic of fertility preservation, which is, I'd say, pretty new, and especially in medical indications, not oncology or social freezing, but medical indications that I think there's a room for this in this particular group of patients. The first thing we have to understand is what do people know? And by people, I mean both doctors and patients. What is the current knowledge? And what are the expectations? Because maybe one of the things that we need to do first is to educate our patients and our colleagues. And this is why one of the reasons why we're here today talking and discussing about fertility preservation. This is one of the studies that was recently published trying to see what young adults know about the aging and the impact on fertility. And this goes linked very closely to endometriosis. Very interestingly, this was a questionnaire done in more than 1,000 Australian university students. So this would be, highly educated students, highly educated population. And interestingly, less than half identified age as a compromise for fertility in women. So still, even simple messages like age is not so well known in general population. But at the same time, most of these students, they wanted to have kids. So there's a disconnection there with the reality and what they do know. The truth is that most of them had unrealistic expectations. They think that, you can have babies until 40, 45, even 50. But the reason that we meet today, and one of the main messages from this paper was that we need to educate young people about the fertility limits. I think we do a good job educating how not to have a baby, but at the same time, we should educate about limits on fertility and how this is not forever, eggs are limited, and some diseases like endometriosis may even compromise further the upper limit of fertility. And at the same time, I think society has to support young adults to be parents at appropriate biological time. We always try to balance our life, and we need to support them balancing their life objective, not only the studies, but the career, finding a partner, and this is becoming more and more difficult. If you go to the other side of the equation, which are doctors, we also can take data from the literature. And this is, again, a recent paper published in JARG in 2018. They did this questionnaire in the USA, and almost 1,000 doctors were asked about fertility preservation. The immense majority agreed that this should be discussed during the annual checkup. The truth is that when patients were young, 18 to 34, only 1 in 4 did discuss this topic with the patient. And this went up to 76% between 35 and 44, which maybe, at least in the early 40s, is way too late. And the main reasons they did not do it before was a lack of time. They're always on a rush. And the second was the lack of training. So I think this type of webinars and publications and meetings are still very much needed by our colleagues to explain to them what are the realistic expectations of fertility preservation. If we go into freezing and vitrification, I think the whole topic of fertility preservation actually did change a lot when vitrification came into place. And the reason is simplified in this picture here from 2007. The main problem that we have with freezing oocytes is that the oocyte is full of water. Freezing a sperm is more or less simple. Freezing an embryo is more or less okay. But freezing an oocyte was incredibly difficult because you have this problem. You see the oocyte here when it's at 0 degrees. When it's -4, you can see the ice crystals approaching to the oocyte. When you go -20, you see the oocyte completely trapped. And -40, you can see like a black dot here is the oocyte full of very small intracellular ice crystals. So this cell is dead. So this is why it didn't work that well. But then in 2006, 2007, vitrification came into place. And you can go from this liquid inside the oocyte into a gel without having this ice crystal formation. And this changed completely the way we practice. I think this was a huge advancement for fertility preservation, first of all, in cancer patients. Then it helped us a lot in fertility preservation for social freezers, women like we're discussing today, endometriosis, but also when you want to avoid OHSS and when you want to accumulate oocytes for PETA or in poor responders. So it really changed the way we practice, we have to say. The truth is that this vitrification was a very nice concept. We did our first study and published in FNS in 2008 with Anna Kobo, who is running our freezing program. And we used the crowd top method, the open method, and we could see how fresh and frozen vitrified oocytes behave similarly the same. This first paper was done with donor oocytes, and we could see that the fertilization rate and the implantation rate and miscarriage rate was exactly the same whether they came from a fresh cycle or they were previously vitrified. And this was actually one of the papers selected for the historic papers at ASRM in the 75th birthday recently. So since 2008, we have been pioneering the use of vitrification in whole Europe, and now in 2020, I think this is worldwide accepted and used globally, especially for oncofertility. I think this is one of the main reasons to use oocyte freezing, also for egg banking in oocyte donation, and also for elective fertility preservation. And here we could include maybe endometriosis, even though it's not purely elective, it's more medical, I would say. The problem with freezing and fertility preservation in general is that when you look at the cost effectiveness, you have to balance these two data. If you freeze too early when you're too young, you have very good results because the eggs are good, but it's very low cost effective because most of these women at young ages, if they freeze, they will never use them. They will get pregnant by themselves. So the usage rate would be very little. If you wait until you're quite older, in the late 30s, early 40s, the results will be significantly lower. And again, the usage rate may be higher, but the number of babies that you will get will be very low. So the effectiveness will be lost. So I would say that the balance, the good time for freezing would range between probably between 30 to 35, 36. This is when if you don't have a plan of having a family in the near future, probably under 35 is the ideal age, but not before 30 because it could be too early. Again, one of the main concepts that we have to have in mind is the expectations. And people tend to think, patients tend to think that if they freeze 5 oocytes, they are freezing 5 babies. And we are fully aware that this is not the case. In fact, there's plenty of data out there that you can use to counsel your patients. This is one of the many studies that you can find in the literature. I think this is a pretty good one, where you can see, this is a paper coming from Harvard, published in 2017. The survival rate of the oocytes in young patients is close to 100%. In older patients, is 85%. So this is the first thing that patients should know, that survival rate decreases with age. And then if you have 10 oocytes, for instance, when you have 10 oocytes, chances of having a baby when you have donor oocytes or when you're very young, under 35, is around 70, 75% with 10 oocytes frozen. But these 10 oocytes, if you froze them when you were 40, the chances will reduce dramatically to 30%. So I think you can use this data to explain patients how many oocytes they should freeze, or at least what can they expect with the eggs that they froze. And the concept of elective fertility preservation goes very closely linked to AIDS. I think AIDS is one of the main problems that we have today when creating families, and the impact on egg survival and live birth rate of AIDS is huge, as you can see here. This correlates very well with the data from Harvard. This is data from Anna Kobo from a group at EEL. You see that when women that freeze oocytes thaw them, if they are under 29, or even under 35 is around 95%. However, this drops to 80, 85 when you go from 35 and beyond. But if you look at the live birth rate, you can see how there's a huge drop after 35. You go down to 28.6 or even 3.7 beyond 40. So you can freeze the oocytes, but if you freeze at an older age, probably is not very, very useful. And here you have a very recent paper published in Nature by the group of Salchapron in Paris. I'm sure most of you here who have an interest in the disease have read this paper. If not, I really recommend you to read it because it's a beautiful review, an updated management of the current knowledge. And in this nice paper, they also discuss when you should offer fertility preservation to your patient without pelvic pain or with pelvic pain, with lesions or without lesions. I think it's a very nice summary of what is the current knowledge and how we should face the problem and when should we discuss fertility preservation to our patients. So we will briefly cover if vitrification affects oocytes from women with endometriosis, what is the pregnancy rate, similar results as in women without endometriosis or not, what is the impact of age, how many oocytes do we need, and if surgery affects the outcome, all of this related to endometriosis. And this data comes from a very recent paper that we just got accepted in Fertility and Sterility. It's still in press, but maybe you can download it already. Actually, this was an observational study in women who had at least endometrioma than 1 centimeter with AMH beyond 0.5 nanograms or at least 3 antral follicles. So we found more than 1,000 women with endometriosis who froze the oocytes, and we analyzed 485 who came back after 2.5 years as the meantime to use them and try to have a baby. If we look at the data here, you can see the response according to the age, and you see how when you have a young patient, you retrieve in these women with endometriomas about 6.6 metaphase 2 oocytes per cycle, which goes down to 4.6 in women beyond 35. But if you have time, most of these women will do 2 rounds of oocyte freezing. So per patient, you can go up to 10.7 or even 8 metaphase 2. And this again goes in line with the expectations of the pregnancy rate that you can achieve according to the number of oocytes that you freeze. If you look at the survival rate, again, in young patients, survival rate is pretty nice. It's slightly lower than in controls. If you remember, survival rate under 35 should go around 95%, it's slightly lower. And in women over 35, again, slightly lower, 80% versus 85. But if you look at the embryo quality, again, age has a strong impact. Younger patients will do mainly embryos type A and B and some Cs. If you go to women, older women beyond 35, most of the embryos will be B and C and some A's, but you can see the huge disagreement here between data of young and not so young women. If you look at the pregnancy rate, you can find per cycle, young women have a nice pregnancy rate. If you have embryos, they will implant normally, 41% versus 30 in women beyond 35. And if you look at the live birth rate per patient, so this is more than 1 embryo transfer, the cumulative live birth will go up to 62% versus 29%. So again, huge difference here in women according to the age. When we look at the response and the impact of surgery, this is quite interesting because women who had no surgery, they had around 10 oocytes metaphase 2 per patient. If they have unilateral surgery, this was reduced to 8.5, but if the woman had bilateral surgery, the response was reduced even further. So the more extended the surgery, the lower the response as we expected. But at the same time, doing the surgery did not improve the quality at all. So if you look at the survival rate in women with no surgery, unilateral surgery, or bilateral surgery, you have the same survival rate, the same pregnancy rate, and the same live birth rate. So again, surgery does not do any qualitative beneficial effect to the oocytes. It's only quantitative damage to the response. Excuse me. Again, if we look at the number of oocytes in young women with no surgery versus surgery, you have much better response in women who had no surgery, 12.5 versus young women who had surgery, 9.1, and same with live birth rate, 72 versus 52. Why? because the higher the response, the higher the number of available embryos to transfer, and obviously the higher the cumulative live birth rate. So this is one of the main messages, that you have a young patient and you're thinking of doing surgery and maybe fertility preservation afterwards. It should be the other way around. I would suggest you to do first the fertility preservation and then do the whole procedure of surgery, as extensive as it may be needed. If we look at the response in young women under 35 and no surgery versus women over 35 with surgery, again, the difference becomes bigger, and same for live birth rate. Young women with no surgery have a very nice cumulative live birth rate, around 72.5%. But if these women were older than 35 and with previous surgery, there's a dramatic drop to less than half. And then we go to the final question, which is how many oocytes then should we freeze? And this is the number needed to freeze, let's say, which has no real answer. I think it's all a compromise between you and your patient. And I think they have to know what are the limitations of the technique and what are the limitations of the ART technology, and what are the expectations according to their age and to the number of oocytes. And here you have in green, young women. This is data from our group, from EEL. In green, you see the young women under 35, and in blue, you see the older than 35 patients in the general program. And you see how the pregnancy rate with 5 oocytes was 15 versus 6, with 8 oocytes, 32 versus 17, with 10 oocytes, 42 versus 25. So 10 oocytes is going to give a child in about half of the patients in young patients, but if they're older, it's going to be only 1 in 4. And this goes up obviously with a higher number of oocytes. But the problem most of the times in these women with endometriosis is that they will never get 15 or 20 oocytes because the response is going to be compromised already. So I think the solution of fertility preservation in general, and also particularly in endometriosis, is that we have moved from skepticism at the very beginning, in 2007, 2008, that people was kind of afraid of freezing oocytes, even with an open device. Then it became accepted by the scientific community, and I think today it's been promoted in a good sense for the benefit of the patients. So the take-home messages for today, I think we could say that basically we as doctors, what we have to do is to inform our patients. This is our main objective: inform the patients and also the general population. One of the first things is that we freeze gametes. We don't freeze fertility, we freeze gametes. So these gametes have to fertilize, and they have to implant, and they have to deliver a baby. So one oocyte is not one baby. I think this is one of the main messages that we have to send to our patients. The patients have to be clearly informed of the chances of success before freezing, to avoid overestimation of the chances, because then there would be a lot of frustrated patients that thought that they had a much higher chance of having a baby. I think we as scientists have to spread the possibilities of the technique, especially at younger ages. I think younger women have to be aware that this is available and discuss this with their doctors and see if it's a good option for them or not. We don't need to scare the population at all, but we have to inform them. And I think this should be done at very early stages when they do the annual checkup. And as I said, I think we should avoid unrealistic expectations by information based on data. But we have to use data appropriate for the patient. We cannot take papers from oocyte donation experience and use this for a woman at 38, because it's not going to be the same as you have seen. This would be way too late. So I think it's important to show the real data to the patient, and according to that, she will be able to make her own choices. And finally, I think oocyte vitrification in women with endometriosis should be discussed, especially when surgery is planned. So before surgery, this should be discussed. And of course, if maternity will be delayed. Thank you very much.
Thank you, Juan. Thank you so much. Can you hear me?
Yes.
Okay. Thank you for presenting your data from your clinic. Do we have any question from the audience?
Hello, it's Dr. Bahar speaking.
Hello.
Hello. Thank you very much for your presentation. Actually, it was really good that we have seen your data. I just want to say that So we are not clear, still not clear that if we need to do surgery or not. We can easily say that if we do surgery, we just get rid of the oocytes and we have lesser numbers of oocytes, but we cannot say that we are, lessening the number of take-home babies. So maybe we just have the high quality oocytes if we do surgery, but the number is lesser. So how can you just resume this?
Well, this is the real question. Thank you for the question, because I mean, we could discuss this for an hour. I think the main challenge for all of us is to identify which women will benefit from surgery. And there are women who do need surgery, especially symptomatic women who are in pain. They cannot postpone the treatment. They cannot think about pregnancy before getting rid of the pain. The problem with surgery, as we all know, is that even if we're very careful and very skilled surgeons, we may compromise the reserve. So the option that we can discuss with the patient is that prior to going for the surgery that could be needed, not routinely, and I think the paradigm here changed, maybe what used to be done 20 years ago, today is not anymore. I mean, you don't do surgery in any patient that you see endometriosis. But I think if we are able to identify those women who do benefit from surgery, then you can discuss with them before doing the laparoscopy to freeze the oocytes and then do the surgery. The concept is that by removing the lesions, you're not going to get better oocytes. The quality of the oocytes is going to be equally the same before or after the surgery.
Juan, I have a few questions.
Yes?
I'm in a practical manner. The first one, do you think the oocyte freezing for endometriosis is a social indication or a medical indication?
I think it's a medical indication, and basically because this terminology is important. I think words are important, and when we talk about medical, it seems that is needed. If we talk about social, it seems that it's kind of well, I want to do it, so I pay for it, I'll do it, but it's not a need. And this is why I think social freezing is moving into non-medical indication rather than social freezing. But I think this is a disease. It's compromised by reserve, and from my point of view, is medical indication for sure.
And the other one, in your data, I noticed there is no difference between the unilateral disease or bilateral disease. Am I right?
Yes, there is a small difference in the response. I think, if I recall correct, it's like 8.5 metaphase 2 versus 8. And then there is no difference in the implantation rate and all the different parameters that we look in the lab. So if you have bilateral disease, you may have lower response, but it's not such a huge difference. We were expecting a much bigger difference because when you look at, I don't know, different publications out there, looking at AMH, for instance, bilateral disease is going to almost destroy your AMH, but we could see a similar to unilateral.
Okay, and the other one, and which patients are candidate for the oocyte freezing? I mean, in endometriosis. I mean, the young one and the older one, and after the first surgery, after the second surgery, or before the surgery. Which one's the candidates?
From what we have seen in the data and what we see on a daily basis with non-medical freezers, women who want to postpone maternity, I think we have to have two things into consideration. Regarding this disease, regarding endometriosis, I think it should be before surgery, not after first or second surgery, because then it's going to be extremely difficult to get a good response. So my suggestion would be even before the first surgery. But again, then you have to combine this with the age of the patient. Let's say you have a very young patient, 21-year-old, who has endometrioma, and she has some pain, want to operate on her. Probably it's too early to freeze the oocytes. So you can discuss with her, and most likely you will not freeze. But if this lady is, let's say, 32, I would definitely freeze the oocytes. But if this patient was 40, then maybe I would try to first do the freezing for sure, rather than doing the surgery, because then it's going to be almost impossible. So you have to combine the cost effectiveness again. If the patient is extremely young, probably is not so much needed. But if you are going to do surgery, my suggestion is to do this procedure at the very beginning.
And the other one, do you concern the AMH level for the patient for the oocyte freezing?
Yeah, we measure AMH routinely to all the patients that are going to go for ovarian stimulation. So we can have the antral follicle count that we will do anyway, correlate that with the AMH, and this will help us to create a realistic scenario for the patient and see, according to your AFC and AMH, more or less this is what we should get in the response. And this again is going to help us to counsel our patients whether they should go for one round, maybe 2 or 3 rounds of stimulation.
Okay.
Dr. Velasco.
Hi.
Hi. Nice presentation. Thank you so much. I have a practical question. For those cases with endometrioma, I think during the egg collection, we also impose a risk of pelvic infection. So is it a major concern for us to consult the patients?
Well, this is a classical concern, and it's a good point to discuss, because we always have this fear that if we puncture the endometrioma, then we will have 100% pelvic infection because of the irritation that it's going to create. The truth is that not so often, but sometimes we do need to cross endometrioma, because otherwise we will not be able to reach the follicles that are behind the lesion. In those cases, we add IV antibiotic. And we haven't had a single case of pelvic infection. But then you have not only my word, but you have data. And there's a very nice publication by Dr. Somigliana in Milano from the group of Paolo Bercellini that you all know. They published in the American Journal of OBGYN a few years ago a summary of more than 200 cases where doing egg retrieval, they had to puncture either voluntarily or involuntarily the endometrioma. And out of those 200 cases, they had no single case of infection. So again, this is always a risk. It's something that we try to avoid as much as possible, not to go through endometrioma. But if you do, and you use intravenous antibiotic, most likely you will be covered. So obviously these are complications that may happen, but it's not such a high risk as we conventionally used to think.
All right, thank you.
There's
Juan.
another question from Dr. Hale from Turkey. He asks if, well, he thanks you, first of all, for the nice presentation, and has a question. Does the size of OMA have any importance during the decision of FP before surgery?
Well, not today. I think the ESRA guidelines are clear that is not the size what is so relevant. Is in the previous version they said that more than 4 centimeters we should operate. I think we all know today that the ESRA guidelines say that you should do surgery regardless the size if the patient is symptomatic or if you cannot reach the healthy ovarian tissue that is behind the endometrioma. So I think obviously we also have to put on top of the guidelines, we have to use our common sense. And if you have a huge endometrioma of 10 centimeters, that you have a not very clear image on the scan, that is going to make you more prone to surgery. But if it's a 4 centimeter endometrioma and you have healthy tissue that you can reach by the needle, probably there is no need to worry about the size.
Okay, thank you for answering the question as well.
Juan, this is Harald. Thank you for an excellent presentation, and thank you for sharing your very actual and fresh data with us. I think it's very important that we all consider these possibilities in our patients when we talk about diagnostic steps and treatment steps. This is the important message, and we have to spread this information within our networks. I have one question. Would you change something in the presence of adenomyosis in those patients?
That's a good question, Harald. Thank you for the question. Because if you have a patient with adenomyosis, the problem is going to come later. I mean, the issue today that we had some problems with the diagnostic criteria, I think is more or less clear. after the naphthalene criteria with ultrasound, the 7 criteria that we all are aware today. But implantation is going to be lower and miscarriage is going to be higher. So I would worry in a second step. So first step, I would do the ovarian stimulation similarly, freeze the oocytes. And then the problem will be when you want to transfer these embryos that you may have a compromised implantation uterus. And then here we may discuss whether to use generic agonists for 3 months, or whether to use a combined pill for a few months, or the Energest or some of these new medication. It won't change the response, it won't change the quality of the oocytes, but it will compromise the implantation rate for sure.
Yeah, thank you. And do you think it's in these cases it's even more important to maybe start with the treatments in lower age?
Well, yes, for sure. And this is a difficult message to get across, because you're talking to women who come to you because of maybe for pain or because they don't want to have a family now. And then after they see you, you're telling them, okay, you have a low ovarian response, you should freeze your oocytes. And because your uterus has adenomyosis, you should be a mother sooner than expected. So this is a very difficult message to get across, because, you know, sometimes they didn't even consider that. But I do think that adenomyosis is progressive, and the older the patient gets, the more difficult it's going to be to have a baby in that uterus. And I think at least we have to let the patient know what we know that could happen, not what will happen, but at least what we do know today that may happen. So she's fully aware that the longer she postpones maternity, the more difficult it's going to be. And that you can more or less stop it by freezing your eggs, but not the uterus. So the younger, the better, for sure.
Yes, I agree. Thank you.
Thank you, Harald.
Do we have another question, another comments?
Dr. Velasco, hi. This is Taner Usta from Istanbul. Normally, I'm focusing on the deep infiltrating endometriosis surgery, and sometimes I face some problem about the decision, which way do I have to follow. Many women in Turkey, especially in Istanbul, are single and they are not married, but we diagnose a deep infiltrating endometriosis, but at the same time, they have endometriomas. When you check the AMH level is
Oh, I think he just...
Yeah, we lost him.
Yeah, we lost him. I think he hit the microphone button. Let me see.
Tana, do you hear us?
Yeah, I put him on.
Can you unmute him, Nadia?
I did.
Okay.
I did, but
did you hear me? Do you hear me?
We could hear you until you were speaking about AMH levels, and that's
yeah. I shortly brief about the case. Normally, I am focusing on the deep infiltrating endometriosis, and many of the ladies are single, and they're about 35 years old or over the 35 years old, and they have endometriomas at the same time. And the main problem is the chronic pelvic pain. When we recommend them the surgery, the main issue is, can we touch the ovary? Can we touch the endometrioma, or they live alone? What would you recommend about these ladies? If the ladies' AMH is normal, do you think that can we touch, or do you think that we can drain that endometriomas?
Well, that's a tricky question, because first of all, draining the endometrioma probably is not so useful. It's just a temporary relief, but you know, in 1 or 2 months, you're gonna have the same lesion again. So probably it's not the best idea. My suggestion will depend on what are the plans for this patient to have a family. Because if she is planning to have a family right away, we know that after surgery of the endometrioma and of the deep endometriosis, you can have about 40% pregnancy rate in 1 or 2 years if the patient is young. If this patient is 38, as you mentioned, she already has a low ovarian reserve, and if not in numbers, at least in quality. So she will have compromised quality of the oocytes, especially anucleosis. At 38, the rate of aneuploidy is going to be as high as 60 or 70%. So if the patient is under 35, I could recommend surgery and then try at home if they want to have a baby. If they don't have a partner or they're not married and they don't want to have a baby in the next 2 or 3 years, my suggestion is always freeze before the surgery and then do the surgery in one step. So you can solve as much as you can in one single step. As we all know, it's much better to do one good surgery than 2 medium ones, because then the second one is going to be extremely difficult. So if you are considering deep endometriosis surgery, then at the same time, do surgery of the ovaries. But before you enter that procedure, my recommendation is freeze the oocytes if the patient is older than 35 or if she's not going to have a baby in the next 2 or 3 years.
Another question, comment?
No, don't have any questions in the chat either. Okay. Anyone, if you want to unmute yourselves, you just have to hit the red microphone if you have a question.
Hello.
Hello?
Yes, hello.
Do you hear me?
Yes?
Yes, but I think there are no more questions, right?
Yes.
I think, sorry.
I have a question for women with history of 1 or 2 surgery before, and with endometrioma bigger than 6 centimeter. Do you agree to make alcoholization of the cyst before egg retrieval? Before egg collection?
Alcoholization, you mean infusing alcohol to
Yes.
do a sclerosis of the
Yes.
cyst?
Mm-hmm.
Well, again, there's some groups that have tried this. They have used to put alcohol or tetracyclines or even methotrexate. And I think the evidence is not in favor of it. And I'll explain you at least our experience, because it seems very attractive when you have women with repeated surgeries. They don't want to go for surgery again. And you can do this procedure transvaginally, which is quite simple, and you reduce the cyst. The problem is that you are going to have, for sure, extravasation of this alcohol or the tetracycline or whatever product you inject in the cyst. And this extravasation is going to create pelvic adhesions, and sometimes you're going to have infections. And here is much more frequent than when you do an involuntary puncture of the endometrioma, as we were discussing before. I know several cases from colleagues across the world that they have not been published, but when you talk about this in meetings, everyone now and then knows a patient who went for this procedure, and she had a severe PID, and some of these women even lost their ovary or the uterus because of these severe infections. They create kind of a chronic infection, and they may not be immediate. It may come 2 or 4 weeks after the procedure. And this is why, even though some papers out there show good results in a limited number of patients, when you go further, I think you start to get this, not completely, of course, not very frequent complication, but if you have 1 in 100, I think that's enough. Because I think it's attractive to go for it because it's doable. And the problem is that you may have a compromised pelvic and a severe infection. In fact, we tried with a few cases with methotrexate a few years ago, women who had 3, 4 surgeries that they wanted to go for IVF or even egg donation, but they had a big cyst. They decided not to go for surgery, and we did the cyst and injected methotrexate. And the first few cases were, as always, with the first few cases, the experience was fantastic. But then in case number, I don't remember what, 10 or 11, we had this patient who 3 weeks after the procedure, she developed fever. She went into the hospital for at least 1 month. She did not lose the uterus and the remnants of the ovaries, but she spent 1 month in a hospital with IV antibiotics, and she was in severe pain and danger. So after that, we completely stopped the procedure because we thought that it was not a good idea. And then again, when you chat about this with colleagues from across the world, I think we all know some cases, and I think it's enough to look for another option that could be safer for our patients.
Yes, but if the patient is necessary to do the third surgery because she has pain, do you think that it's better to alcoholizate the cyst and do sequential IVF and then the surgery?
I think
instead to do the surgery, the third surgery?
No, not really. My recommendation is not to inject anything in the cyst because you may have a severe problem. My recommendation is that the patient needs surgery. If she needs surgery, you plan the surgery, and if she wants to freeze before the surgery, you stimulate the patient with the endometrioma, don't worry, and then you can do the retrieval, aspirate the follicles, and then do the surgery. But surgery is going to remove the pain, not the alcohol in the cyst.
Okay, because I operated 3 cases with that has history of infection after IVF, but I think the reason of infection was not the puncture of the endometrioma. The reason was the puncture of the bowel, because they had deep endometriosis. And maybe the doctor, when punctures the cyst, punctures the bowel too. And this is a risk of infection after egg collection, not to puncture only the endometrioma.
Well, yeah, I mean, that's a complication that could happen, but I think with the scanners that we use today, I think it's very difficult to confuse the ovary with the bowel.
Yes, but in deep endometriosis, with a deep nodule in the bowel, sometimes the ovaries, it's very attached of the bowel. It's not a mistake. I think was not a mistake of the doctor. Sure, was not.
No, I don't know. I think that could happen, but then if that was common, then we should see this very frequently, and it's quite seldom that you see these infections after oocyte retrieval in women with deep endometriosis. So I'm not saying that it was a mistake. I'm just saying that I think it's, maybe you want to retrieve every single follicle that you see because these are usually poor responders. And sometimes I think you have to refuse to get maybe the last 1 or 2 follicles because you may get into dangerous areas and just work with the oocytes that you collected so far.
Elvira, this is a different issue. And you are saying before the surgery, you are saying that if she has the deep endometriosis, do we process the IVF or the surgery?
Usually,
the other one is different. Before the surgery, do you do the ceftriaxone agents for the endometrioma is different issue, and your concerning is different issue.
Usually, before surgery, I make sequential IVF. I do egg collection and then surgery and then embryo transfer. We plan the embryo transfer. I think this is correct for the patient, especially for the patients that had history of more than 1 or 2 surgery. And for patients that over 35 years old with very low antral follicle count, I think it's an option. I don't know, but we have some experience with alcoholization the cyst, do egg collection, and then the surgery.
Okay, thank you.
Thank you.
Do we have another question, comment?
May I have a question?
Please, Jeff.
As compared to the patients for social egg freezing, age-matched controls with the endometriosis patients, according to your data. So do they perform the same with the age-matched people for social egg freezing?
Right. That's a good question because we also have this question whether the endometriosis has a quantitative or qualitative damage. And what we see in this data set of almost 500 women is that the survival rate and the pregnancy rate in young and older women with endometriosis is slightly lower than in women without endometriosis. So when you freeze oocytes in healthy women, survival rate is around 90–95%, and with endometriosis is around 85%. And when you go to pregnancy rates, again, it's like 5–10 points less than what it should be according to it. So even though most of the time we don't see a qualitative damage, I think there is enough data today that to understand that oocyte quality is not the same and embryo quality is not the same. Mainly you have less embryos, but also the quality is slightly lower.
Thank you. Thank you.
Juan, do you have any experience about the ovarian tissue preservation instead of the oocyte vitrification?
Well, we do ovarian tissue freezing in Valencia, not in Madrid. The problem is that the ovarian tissue freezing is still experimental, and for patients is not probably the best idea. But of course, we have done a lot of them, almost 1,000 cases with cancer patients, but not with patients with endometriosis. I think that the fear that we always have with cancer patients of reintroducing the disease when you transfer the thaw tissue could be the same with endometriosis. Maybe you freeze the tissue and then you reimplant the endometriotic ovary, and then you will have the disease again. So it's an option if you're, it depends on your setting. If you have a setting where oocyte freezing is not working properly, or you're not very confident with your freezing program, then go ahead and freeze the tissue if it's legal in your country, because as I said, here it has to go through a research protocol, at least today. Hopefully it will change. If you have a reliable freezing program, my suggestion, my recommendation is to freeze oocytes, because when we compare the outcome, the babies born after tissue freezing versus oocyte freezing works significantly better.
Thank you. Any other questions? Actually, we have a lot of questions for you. Thank you so much for tonight. I learned a lot of things from your presentation, from the questions. It was fruitful for us. Actually, the next one will be next month, 14th of the April, and Dr. Krentel will talk about adenomyosis, which is hot topic, another one. You were the first one, Juan. I mean the webinar. Always you are the first. And thank you so much. You accepted it. It was our real pleasure for us.
Oh, thank you.
Spend some time in these hard days. Thank you so much.
It was a real pleasure. I'm happy to be the first one to open this webinar series. And thank you, Engin. Thank you, the EEL, for your interest. And thank you, all of you, for attending this webinar. It's been a real pleasure.
Thank you so much. Good evening.
Muchas gracias.
Gracias,
Very
Harald.
nice.
Juan.
Very good start. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.